Good evening, and a warm welcome to our broadcast. Tonight, we delve into a profoundly important and increasingly discussed question. Are mental health treatments biased by culture? This issue sits at the heart of global mental health, challenging us to consider how well our current approaches serve diverse populations worldwide. It's a complex topic, touching on everything from diagnostic criteria to therapeutic relationships. To explore these nuances, we are joined by two distinguished guests. Dr. Kenji Tanaka, a cultural psychiatrist, argues that many treatments are indeed significantly shaped by Western cultural assumptions, and Ms. Aisha Khan, a global mental health advocate who believes in the universal applicability of core principles, provided they are adapted with cultural sensitivity. We anticipate a thought-provoking discussion.
Thank you, Dr. Reed. It's a privilege to be here. My contention this evening is straightforward, yet critical. The dominant paradigms in mental health treatment, largely originating from and validated within Western, educated, industrialized, rich, and democratic, or weird societies, carry substantial cultural biases. These are not minor oversights. They are fundamental skews that can compromise the efficacy and appropriateness of care for a global majority. Firstly, let's consider our diagnostic frameworks, such as the DSM or ICD. While intended to be universal, their development has been overwhelmingly influenced by Western conceptualizations of illness and normality. This means they may not adequately capture culturally specific syndromes or expressions of distress. For instance, what one culture might interpret as a spiritual emergence or a communal response to trauma. Another, using these standard tools without deep cultural insight, might label as psychosis or an individual anxiety disorder. This isn't just a matter of terminology. It's about fundamentally misunderstanding and potentially pathologizing valid human experiences. Concepts of self, the very definition of illness, and how emotions are expressed and valued differ dramatically across cultures. Secondly, many mainstream therapeutic modalities, such as cognitive behavioral therapy or traditional psychoanalysis, often champion individual autonomy, direct verbal articulation of problems, and cognitive restructuring. These are laudable goals in some contexts. However, in many collectivist cultures, the emphasis is on familial or communal harmony, indirect communication, and somatic or spiritual pathways to healing. Imposing a therapeutic model that prioritizes the individual's explicit, introspective journey can be incongruent, even alienating, for someone whose identity and well-being are deeply interwoven with their community. Finally, there are systemic issues. Research in mental health is predominantly conducted in Western countries, with Western populations. This creates an evidence base that may not be generalizable. Furthermore, there's often a significant lack of culturally competent practitioners who can bridge these cultural divides. This can lead to misdiagnosis, underutilization of services by minority groups, and treatment plans that are, at best, suboptimal and, at worst, culturally insensitive or even harmful. Therefore, I firmly advocate for the urgent development, rigorous validation, and broader recognition of more culturally grounded mental health approaches that respect and integrate diverse worldviews.
Thank you, Dr. Reed and Dr. Tanaka, for outlining your perspective. I agree that the conversation about cultural bias in mental health is absolutely vital, and I appreciate the points Dr. Tanaka has raised. However, while acknowledging the critical importance of cultural sensitivity and the historical dominance of Western models, I believe it's an overstatement to characterize all established mental health treatments as inherently biased to the point of being universally ineffective outside of Western contexts. Many core principles of these treatments, I contend, possess cross-cultural relevance when they are applied thoughtfully and adapted appropriately. Firstly, it's important to recognize the evolution within the field. While Western models did historically dominate, there has been a significant and positive shift towards cultural psychiatry and numerous global mental health initiatives in recent decades. We are learning, and the field is adapting, albeit perhaps more slowly than some would like. This includes a growing body of research into cultural variations in mental health and illness. Secondly, many evidence-based treatments address fundamental human psychological mechanisms that are, arguably, universal. For example, the fear responses targeted in treatments for anxiety disorders, or the cognitive patterns associated with depression, are recognizable human experiences across different cultures, even if their specific manifestations, triggers, and interpretations vary considerably. The core aim of alleviating suffering through understanding and modifying these processes can still hold true, provided the approach is flexible. Thirdly, and perhaps most importantly, we have numerous examples where Western therapeutic models have been successfully adapted and integrated with local healing traditions in diverse global settings. Culturally adapted CBT, for instance, has shown promise in various non-Western populations by modifying language, incorporating local metaphors, involving family members, and respecting community values. It's not about a rigid application, but a flexible and collaborative one. The key is not wholesale rejection, but careful, respectful adaptation and integration, often leading to hybrid models that are more effective and acceptable locally. Therefore, our focus should be on enhancing this cultural attunement, fostering collaboration, and empowering local communities to shape mental health solutions that resonate with their realities, rather than discarding established knowledge altogether.
Thank you both for those comprehensive opening statements. Dr. Tanaka, you raised significant concerns about diagnostic categories potentially misinterpreting culturally specific experiences. Could you offer a specific instance where a Western diagnostic approach might pathologize a behavior or experience that is considered normal or non-pathological within a different cultural context? This would help our audience understand the tangible impact.
Certainly, Dr. Reed. A clear example can be found in how some cultures experience and express grief. In certain collectivist societies, prolonged periods of communal grieving, which might include vivid experiences of sensing the deceased's presence or engaging in elaborate rituals, are not only normal, but are essential for communal healing and reaffirming social bonds. However, if a clinician strictly adheres to Western diagnostic timelines for bereavement, or interprets vivid spiritual experiences solely through a lens of potential psychosis, without understanding the cultural script, they might incorrectly diagnose a, quote, prolonged grief disorder, or even a psychotic disorder. Another example is the somatization of distress. In many cultures, psychological suffering is primarily expressed through physical symptoms, headaches, fatigue, bodily pain, rather than emotional language. A clinician unfamiliar with this might focus excessively on medical explanations, missing the underlying psychological distress, or conversely, dismiss the physical complaints, leading to inadequate care.
That's a very illustrative example, Dr. Tanaka. Ms. Khan, considering Dr. Tanaka's point about the potential for misinterpretation, how do you view the adaptability of current diagnostic systems like the DSM or ICD? Are they sufficiently flexible as they stand? Or do you believe there's a pressing need for fundamentally new frameworks to effectively address these profound cultural nuances and avoid such misinterpretations?
That's a crucial question, Dr. Reed. I acknowledge the limitations of current systems. They are not perfect, and historical biases have certainly shaped them. However, significant efforts have been made to enhance their cultural sensitivity. For instance, the DSM-5 includes the Cultural Formulation Interview, a tool specifically designed to help clinicians gather information about cultural factors relevant to a person's illness and care. The ICD also increasingly incorporates cultural considerations. So while these systems could undoubtedly be improved and made more globally representative in their development, I don't believe they are inherently so flawed that they require complete abandonment for entirely new frameworks. At least not yet. Often the greater challenge lies not in the tools themselves, but in their application by clinicians, who may lack sufficient cultural competency, training, or humility. The most sophisticated tool, if used without understanding its context or limitations, can still lead to errors. Therefore, robust and continuous training in cultural psychiatry for all mental health professionals is paramount, alongside ongoing efforts to refine these diagnostic systems through diverse global input.
This brings us to the interventions themselves. Ms. Khan, you spoke of adapting treatments and the success of some culturally adapted models. Dr. Tanaka, from your perspective, when we talk about these adaptations, are they generally sufficient? Or do they often merely scratch the surface, perhaps changing language or using local examples, but failing to reconcile deeper cultural incongruities with the foundational philosophies of some Western therapies, such as their emphasis on individualism?
That's precisely the concern, Dr. Reed. While I commend any effort towards adaptation as a positive step, many adaptations, in my view, remain somewhat superficial. They might translate materials or involve community figures, which is good, but they often don't fundamentally alter the core tenets of the therapy. For example, the strong emphasis on individual cognitive restructuring in CBT, or the focus on early childhood experiences and intrapsychic conflict in some psychodynamic therapies, can still clash with cultural worldviews that prioritize collective well-being, present-focused problem-solving, or spiritual explanations for distress. If the underlying philosophy of the therapy, its theory of change, its view of the person, remains deeply rooted in Western individualism, then simply tweaking the delivery may not be enough to ensure true cultural congruence and effectiveness. We need to ask if we are truly adapting the therapy to the culture, or trying to adapt the culture to the therapy.
I understand Dr. Tanaka's concern about superficial adaptations, and it's a valid point that we must guard against tokenism. However, I believe that deeper, more meaningful adaptations are indeed possible and are being practiced successfully. These go beyond simple translations. For instance, adapting CBT for depression in some South Asian communities has involved integrating family members into therapy sessions, aligning therapeutic goals with family responsibilities, and using culturally resonant metaphors for cognitive restructuring. In other contexts, interventions have successfully incorporated traditional healers or spiritual leaders as collaborators, blending evidence-based techniques with indigenous practices. This requires a truly collaborative process, where Western-trained professionals work alongside local experts and community members, not as instructors, but as partners in co-creating interventions. It's about finding the synergy, the common ground, and being willing to modify even core components when necessary, as long as the fundamental aim of alleviating suffering and promoting well-being is achieved. It's an ongoing process of learning and refinement.
In closing, I must reiterate my primary assertion. Cultural bias remains a pervasive and significant challenge in contemporary mental health practices. This isn't an abstract academic debate. It has tangible, often detrimental, consequences. We see these consequences in the significant disparities in mental health care access and outcomes for marginalized communities, the erosion of trust when individuals feel their cultural experiences are misunderstood or invalidated, and the provision of care that, for many, may be ineffective, inappropriate, or even harmful by imposing alien values. The current gold standard treatments, predominantly validated on Western populations, cannot be presumed universally applicable without critical scrutiny. Therefore, the path forward requires a paradigm shift. We must urgently increase investment in researching, developing, and validating indigenous psychologies and culturally specific interventions that emerge from within communities themselves. Furthermore, systemic reforms are essential in how mental health professionals are trained, demanding a curriculum rich in cultural humility and competency. And research priorities must be reoriented to champion global perspectives and address these deep-seated biases. Only then can we hope to achieve truly equitable and effective mental health care for all.
As we conclude, I want to reaffirm my belief that while cultural biases have indeed been a historical issue and require continuous vigilance, the most constructive path forward lies in diligently enhancing our cultural competence and thoughtfully adapting evidence-based treatments. We should build upon the shared aspects of human psychological experience, the universal desire for well-being, the common pain of mental distress, while respecting and integrating the rich diversity of cultural expression and understanding. Significant progress has already been achieved in cultural psychiatry and global mental health, and I am optimistic about our collective potential to develop truly global and equitable approaches. This requires robust, collaborative, cross-cultural research, not to simply export Western models, but to co-create new knowledge. It demands comprehensive training for practitioners that focuses on cultural humility, adaptive therapeutic skills, and an openness to learning from other traditions. Crucially, it necessitates genuine partnerships between Western and non-Western experts, local communities, and traditional healers, fostering a spirit of mutual respect and shared learning. Our goal should be an integrated, pluralistic approach to mental health.
Thank you, Dr. Tanaka, and thank you, Ms. Khan, for your incredibly insightful and engaging contributions to this vital discussion. You've both articulated your positions with clarity and passion, highlighting the complexities involved. If there's a clear consensus emerging, it's the undeniable, paramount importance of integrating cultural context into every facet of mental health, from diagnosis and research to treatment and policy. Whether this involves the creation of entirely novel models rooted in specific cultural traditions, or the careful, profound adaptation of existing ones, the needs of diverse populations must be central. We hope this debate has stimulated further thought and encourages our audience to continue reflecting on the multifaceted nature of culture and its profound impact on mental well-being. Thank you for joining us. Good evening.